have our last but not least speaker. So Dr. Dalia. So she's joined us. Yeah, that's great.
Hi, Dr. Sam. How are you? Yeah, I'm glad. Thank you so much for inviting me here. And thank you for Dr. Pamela for the great presentation. That would be very relevant to what I'm going to be speaking about today. So
yeah, this is why we have you both at the end in one session. I think they are very complementary to each other. So Dr. Dalia Hamdy is the founder of Apex Health Services Limited, and she's also associate professor of clinical pharmacy in Calgary in Canada, Alberta College of Pharmacy, and she's graduated from Faculty of Pharmacy, Alexandria University. She was one of the founding members of the Egyptian Young Academy of Sciences, and now she has moved outside Egypt completely to Canada to continue with her career in clinical pharmacy. And she's going to talk to us today on the role of pharmacists in personalization of therapy in the light of globalization. And this really fits very well with the previous lecture of the pharmacogenomics. So please, Dr. Dalia, you can start sharing your screen.
thank you so much, Dr. Sam. Let me start sharing my screen. And here we go. Just put those ones down in here. Okay. So today I'm going to talk about pharmacist roles in personalization of therapy. My background is PhD in pharmacokinetics, and I developed the interest in pharmacogenomics since around 2012 or something like that. And since then, I've been working a little bit about pharmacogenomics. It's a new science. And so today, our outline would be, first of all, what is globalization, which is the main theme of our talks today, how precision medicine and pharmacogenomics fits within this globalization term that relates to healthcare system. I want to point out how the world, actually, like not just the US, not just Canada, Europe, Australia, and now Egypt is joining the team by working more on the new project announced. And what are the challenges out there? If we want to implement pharmacogenomics into our healthcare systems, what are the challenges that we are all facing? Dr. Pamela kindly mentioned a few of those, and I'm going to get deeper into that. Some preliminary data and research activities done by my research teams. And again, this is very primitive, and my target was not like towards the actual clinical research, but rather towards the implementation and use. My background is in community pharmacy, and this is where I usually focus more and tend to grab the focus where all pharmacists can contribute. Examples of how a pharmacist can implement. So I'm going to give you a live example of how can you implement the precision medicine, what are the resources you can be using, what guidelines are out there. Dr. Pamela again mentioned the CPIC and the Dutch group, which are the two major groups out there. There is also the Canadian group, and where can you find those information, where can you find those guidelines, and how to implement them into the therapy management that is the basic role of the pharmacist all over the world. So first of all, when we talk about globalization, we're basically talking about people, ideas, goods, mingling around the world, moving freely around the world, and how integration between different cultures, the governments, the economies are affected. And this is how we see the whole idea of globalization. And because we're dealing with globalization, we started to deal with new terms in healthcare systems. The new terms includes the medical tourism. The new challenges include diversity. So basically, as Dr. Pan said, like within the US itself, so some areas would have certain ethnicities, some other areas would have other ethnicities, and so on and so forth. This is because of the migration, because of people moving all around the world. Medical tourism would allow people with the certain economies that provide healthcare systems that are cost effective medication costs that are cost effective, to have more people coming to those areas. Or those people come with different ethnicities, with different genes, with different scenarios. So if we want to deal with personalized or precision medicine, we have to actually accommodate our therapy, our empiric therapy to those patients. And you know, more and more we tend towards personalized or precision medicine as a tendency in healthcare systems, which provide more accuracy, which provide less side effects, which provides more saving of costs, less hospitalization, and you can count till like forever when it comes to this this topic. Okay, when we talk about precision medicine, we're talking about sort of tailoring. Okay, I'm not giving one dose to everyone. I'm not. I'm sort of individualizing the therapy and the therapy management to each patient. Okay, this has been going on for a while. So we're moving from the idea, same thing that Dr. Pamela had did share, from the idea that one dose and one medicine fits all, to personalized medicine. But we cannot do it to each and every single individually in general. We'd rather divide people into groups, whether groups that have similar age, whether groups that have similar physiological parameters, similar kidney function, similar liver function, similar genes. So we start putting people into groups, and within those groups, we tend to get trends, and through those trends, we try to individualize the therapy, okay? Now, what are the pharmacist's role in general? So pharmacist's role is therapy management, okay? And therapy management differs from, and the practice differs from one country to the other, okay? In Canada, in Alberta, in where I practice, the pharmacist has gone the whole 9 yards. So we even reached prescribing medications to a certain extent, so we can diagnose and we can prescribe according to your knowledge, according to your background. We can do a lot of tests. So pharmacy is a point of testing. We have access to what we call a national healthcare data system. We call it Netcare over here. So basically we can check where the patient last dispensed his medication, what did he take exactly, what are the lab works that were done over there. You know, so it's a lot of, the practice is very advanced in Alberta. So basically, in other places, the therapy management would include therapy initiation, putting the loading dose and the maintenance dose, and then eventually therapy monitoring. And this is also what people do in Alberta, in addition to the advanced practice. In addition to that, for example, we're doing injections in the pharmacy, we're doing vaccinations in the pharmacy, we're dealing with travel vaccinations. So it's a lot of practice aspects, and that basically needs another talk to be, you know, to give you an idea of how the practice scope can be advanced and widened. But when we talk about precision medicine, so since the pharmacist role includes the therapy initiation and the therapy monitoring, so the pharmacist role needs to focus on precision medicine. Okay, so are we already doing precision medicine? In fact, we are doing already precision medicine, but we are doing it missing one thing. So we're doing it, that we're doing the TDMs. A lot of pharmacies in hospitals doing the TDMs for a narrow therapeutic window medications, right? We have special population considerations. So we have, when we have the kidney function, or when we have certain EGFRs, when we have specific liver functions, we have the guidelines for that, and we adjust doses accordingly. Like, this is what we are actually doing. Maybe not in every place, maybe not in every practice setting, but pharmacists actually do that. Age is one of the things. So basically, we also see drug-drug interactions and adjust doses accordingly. We also see drug-disease interactions and adjust dosing accordingly. So if somebody's telling you that we're not doing the precision medicine, that's not true. We are doing precision medicine. We are way doing it. We have been teaching the pharmacokinetics and the pharmacodynamics since years back, but we're not doing it with the current scope or with the current definition that we're talking about today. So what is new? When I'm saying precision medicine, okay, let's care about precision medicine. Well, Dalia, we have been doing it for years. Yes, we have been doing it for years, but what we have been missing is the drug-gene interaction. And this is what pharmacogenomics is about. Drug-gene interaction. If we have a certain gene, there is a drug-gene interaction that we need to consider. Okay, So basically, drug-gene interactions started when the technology starting to get more advanced, and we started to see polymorphisms, and we started to identify different forms of the same gene, so alleles, as Dr. Pamela has mentioned. And most of those alleles start by having what we call SNPs. So it's a single nucleotide polymorphism or single nucleotide variant. But this variant has been consistent in at least 1 to 2% of the population. Now this variant has been actually present and documented, and actually have a clinical impact because it has been repetitive among a lot of population. So I can start dividing people into those groups. So when we hear the word SNP or SNP, that's a polymorphism that has been, or that's a variant that has been actually consistent in at least 1 to 2% of the population. And now I have to consider that, and I have to keep that in mind, and we have to study and divide people according to those alleles or difference. Now, what is pharmacogenomics? And when we talk about pharmacogenetics or pharmacogenomics, we're talking about the effect of DNA sequence variation, the changes in the DNA, and how would it affect the drug response. And that effect would be at the PK level or at the pharmacokinetic level, changing the metabolism, the clearance, and how the drug behaves inside the body, or it could be on the action levels, changing some of the receptors or you know, other places, so receptors or transporters that are related to the PD. Okay, so how the PGX and the PK and the PD, they are all related, and actually how the PGX is actually some sort of an advancement where the PK have stopped. Basically, we have to move a little bit more forward where we include the genes as another cofactor in whatever we have been using in our mathematical equations and in our consideration and in our therapy management, taking decisions for how to deal with the patient. Now, we need to apply genomics in precision medicine. So I'm a place and I want to say, I want to wake up tomorrow and I want to say, you know what, I want to apply precision medicine, I want to apply pharmacogenomics. What can I do? Now, to be able to do that, you have to tackle the following challenges. And this has been done since years now, almost, I would say. It differs from one practice to the other, from one part of the world to the other. But I'm going to talk about the achievements that Canada and the US and North America in general have achieved to tackle those things. So the first thing is the technology. Okay, and when we see technology, we see technology and cost. And there are two types of testing out there, two types of genetic testing out there. There is the genetic testing for diagnostic purposes, okay? And so basically when I see a certain gene, I say this person is more prone to having this sort of disease, and as such, you know, and when we deal with those, there are a lot of ethical considerations, there are a lot of things. This is not pharmacogenomics, this is diagnostic purposes, okay? And the tests for those are different, the ethical background is different. It is very important as well, and but this is, I would say, would be more concerned with physicians more than pharmacists. The second type is the genetic testing for therapy management. And when we talk about genetic testing for therapy management, this is the PGX. This is where pharmacists actually need to focus and need to consider. And when we are talking about genetic testing for therapy management, we're talking about transporters, we're talking about enzymes, phase 1 and phase 2 enzymes. Cytochrome P450s are mostly the ones we're looking at. Transporters as the SLCO1B1, as the one that Dr. Pam was saying. We have receptors like the mu receptors that are used for morphine and codeine and those things, so the OP or it will going to come later, okay? The commercial kits are now available. Like years back, the commercial kits were only 1 or 2 in the market. Years before that, the commercial kits were not available at all. The recreational kits, as the 23andMe and others, are now trying to jump into the medical genes or the medical alleles as well. So with all this competition, the prices are expected eventually to go down with the technology and the competition between those companies. Technology is expected to speed up, and we should expect to see more and more affordable things. At the beginning, $150 or $200 was used to measure only one gene, possibly. The genes to be measured, it has to be through laboratories. Nothing is commercial and nothing is available. So there is a pro and con. It's available now, it's commercial. It's still not that much affordable for everybody. It ranges between 150 and 500. The one that I have implemented in my community pharmacy is called My DNA Company. And this one is, the lab is based in Australia, and it costs around $200 for a set around 7, 8, or 10 genes. There are a few others in the US labs, and there are a few others in the European labs. And I mentioned the competition is very healthy because the competition out there works towards making things more affordable. Okay, the second thing is whether insurance companies are going to cover it or not. Until now, for example, in Canada, it's somehow by exceptions, and it requires doctors' prescriptions. I haven't seen a lot of people that were already covered for the PGX testing kits, at least the commercial ones. Some of the other testing, for example, for warfarin or something like that, some of them are covered by the government insurances, but not all, and they require special requisitions and special cases. Whether the commercial kits are going to be covered or not, this is again a question that we are working towards. This is a list I worked with one of my undergrad students, and we made a list of all the alleles that are found in commercial kits that were found in Canada. That's back in 2017 when we did this table. And alleles, as I mentioned, they take a star, okay, and then they take a number or a number and a letter. As you see, most of them relates to the cytochrome P450s, which are the phase 1. There is the COMT in here. There is the one related to the warfarin. We have here this one relates to the statin, the OPRM1 that relates to the receptor or the mu receptors that we call for the codeine, for example. So we have different alleles in there, okay? And those are all found in commercial kits, so you can know your allele that relates to those transporters, enzymes, and receptors from commercial kits, and more are added every day as the technology goes on. Now, how to apply, again, the other thing would be the ethical and legal considerations, okay? New terms, very new terms are going to be out there. And when I say new, I'm talking about scope between 7 to 8 years, around 7 to 8 years, maybe 10 years from the day to day. So one of the new terms is genetic discrimination. And what is genetic discrimination? Genetic discrimination is a person deprived from his right, for example, to get insurances, or to get a job opportunity, or to get a promotion, or to get something like that due to his genetic makeup. So we have to make sure that as we handle this genetic information, who gets access to this genetic information. So in order to prevent something that could happen in the future, that we will deal to discrimination between people due to the genetic differences or genetic makeup. So this is something that has to be strictly and very clearly addressed, and that has been happening in North America, in US and in Canada. And I will talk about the regulations about that. The second thing is the genetic stigmatization, or how the community deal with you. For example, people would look at you, okay, or deal with you differently because of, for example, stigmatization. People deal with you differently because, for example, of your skin color, or because of your ethnicity, or because of something like that. So the genetic stigmatization, the same thing, but how the community deals with you due to the genetic makeup. And this is why the the data handling and the regulation that relates, and the ethical and the legal rights of the people, especially upon the more application of the PGX, is very, very, very important. It requires lectures and lectures to talk about that. Okay. Also, we need to, when we do the service, we have to put in consideration the ethical rules, the general ethical rules that we work with as pharmacists. So justice, for example, you cannot say this patient can afford to do the genetic proficiency. So basically, what you do and to stop the harm, when to share the information and when not to share it, how to make sure that the patient is getting the best of it. If we're talking about genetic information that relates to diagnostics, what are the rights? And this is inheritable genes, for example. So a question would arise up if a person comes in a clinical trial and testing a certain gene that would result in certain diagnostic, for example, cancer. Or something that is inheritable, and you know that he carries this gene. Basically, his brothers and sisters would carry it, his mother might carry it, or his offsprings might carry it. Who should know this information? can they live with it? Can you live with the idea that your offspring, 99% are going to get this disease? You have to counsel the patient on that, how to deal with that as a pharmacist, whether in the clinical trial or whether as a pharmacist in the community. What ethics are there behind that? The last thing is the autonomy. Okay, the patient has the right to accept or to reject getting the knowledge. You know, you don't have to force the patient to do anything. You cannot just tell him, okay, he refuses to know whether he carries the cancer or not, and he refuses to go for the testing, despite that he knows that this testing is going to work for him. You cannot just, you know, take a blood sample saying, okay, we're going to do those checkups and do the test for him anyways. You know, autonomy, you know. So there are a lot of ethical things that have to be applied when it comes, or the pharmacogenetics has to go again and be defined under those major ethicals, with a lot of cases that are happening to identify that. But this is another thing that you need to tackle. North America has tackled that already. There is the Genetic Non-Discrimination Act in Canada that was developed in 2007. That is issued in 2008, and I have this is a paper. Okay, so if you put this on Google, it will come out. The paper would come out. You can check this. This one here is the link to the GINA website of the USA, and both of them talk about the access. Who have the access? Who have the right? Who have the possession of this information? Now, healthcare professional knowledge and population awareness. And this is very important. Healthcare knowledge, you need to have the capacity to interpret the results. If you get a report, you need to have the capacity to interpret the results. What does the results mean? You need to have the capacity to, once the results are out, to incorporate them in the bigger picture. We're not dealing with numbers. We're not treating numbers. We're not treating alleles. We're treating people. So do I have only the drug-gene interaction in here? Is there another competitive inhibition that is happening between? Is there another drug-drug interaction occurring at the same time? Do those patients carry a normal renal function, normal liver function? So I have to incorporate this data in the bigger picture of the patient. So I have to have the comfort level to understand and then eventually take this information and incorporate it among the bigger picture for the patient, because I'm treating the patient, not just the drug disease interaction and just the guideline that I'm having. I have to have the bigger picture and the bigger scope, and this is where pharmacists need to jump in, because we have the PK background, we have the PD background, we have everything. When it comes to those calculations, this is the pharmacist role. Okay. So basically, we need more confidence also in identifying eligible patients to adjust the healthcare costs. So people with specific ethnicities that have high prevalence of certain alleles that are more prone to certain drugs. Okay. We have to, there are the resources, like we use e-therapeutics, we use UpToDate, we use Lexi for the drug interactions and for the dosing patterns. Where can we find the guidelines and where can we find the resources to deal with the PGX? So in 2017, I did an undergraduate research. I got 2 undergrad students from University of Alberta in Edmonton, in Alberta, and I worked with a professor. By that time, I didn't join University of Alberta as a member yet. I actually did afterwards. Dr. Mayo was the U of A person. He's a professor over there, and he's the one who initiated the pharmacogenomic courses in University of Alberta that I'm now honored to be continuing doing. And this is, I started to compare. We have an N of 70 student pharmacists response, and we had 105 student responses. And as you see, how familiar are you with the pharmacogenomics? Students were more familiar because the topics now has been studied. Now, when it comes to graduating pharmacists, we had different levels. So some of them got to know it through the BSc values. Some have got to know it through the CE, like continuing education sessions, and some of them actually took it as undergrads and CE. So as I mentioned now, so basically we need to work on that. The second thing was the people awareness. We got 112 patient responses. Have you heard of pharmacogenomics before? And basically most of the patients that we dealt with, and those patients were mostly from the Fort Saskatchewan area where my community pharmacy is in Alberta. So 79% of them were not, but they were interested to receive more information about this issue. 40% were willing to pay for the test, but they said that $100 or $120, something like that, would be more affordable for them. More than that, they were not so comfortable paying for the amounts. Would you be comfortable? And now I have to mention also that Dr. Pamela said that like 350 isn't so much of an amount in the US. I have to mention that the healthcare system in Alberta and in Canada in general is government funded. So basically the government pays for the hospitals, the government pays for the for a lot of services, not the medications, though this goes through insurance companies, but the healthcare system in Canada is funded. So if you ask a patient to pay $100 or $200 or $300, that's a lump sum of money for a patient, for Canadian patients. Would you be comfortable with your genetic data being accessible to healthcare providers? Basically, if I get to know, if you get to know your genetic data, would be comfortable sharing it with your doctor, with the prescribing nurse, with the prescribing pharmacist. And 73% were comfortable sharing it with other healthcare professionals as well. There was a good question, when do you think you need to apply the pharmacogenomic testing? And 9% disapproved the testing altogether, 9 people out of the 112 disapproved it totally. 41 said that they suggest doing it at birth. 34 suggest doing it between the adolescence area. Some of them thought, okay, different ages. The ethics here would be, okay, who have the rights? Can the mother and the father take a decision for a child to do their testing? And when they grow up, they don't know such results, for example. Because some of the pharmacogenomic testing, despite their therapy management, they have correlations to some diseases as well. So because as for example, those enzymes, they metabolize the exogenous materials, they do metabolize similar endogenous materials, which indicate certain chemistry imbalance within the body, which indicates certain diseases. So is the child, when he grows up, would he be comfortable knowing this information? Does the parents have the right to do this decision for them? But when it comes to weighing benefit risk thing, if I can prevent this child from having side effects for the drugs and it's necessary for them to get to know it early in their life, is it okay or not? So those are things that we're all facing. This is worldwide. The whole science is new worldwide. Yes, some people did manage to get some researches, and this is how we get the guidelines that I'm going to be talking about. But in general, the application in clinical setting is all new. The actions taken towards this challenge when it comes to knowledge and stuff and awarenesses. So universities starting to implement pharmacogenomics competences in their pharmacy curriculum. The competences, they differ. Some people put it only as elective courses. Some curricula put it as one course per year, for example, specific credit hours, and some universities integrated into different courses that each of them would speak about it, similar to the TDMs, for example, or the clinical kinetics in terms of the integration of courses. The competences, there is a blueprint of the competences that covers the PGX for pharmacists. It was initially done in 2003, and it was revised again in 2017, and this is the link to it. There are a lot of CE units and a lot of programs similar to the very nice table that Dr. Pamela did share to share with community pharmacists. There are currently research grants, including one that I did take recently from the Alberta Pharmacists Association to educate peer pharmacists and implement the services in different community pharmacies. So there are a few grants out there also working on the same purposes. There are a few grants in BC doing the same thing, few grants in Montreal doing similar stuff. In addition, that the curricula and the PharmD students, and we have already graduated 2 or 3 batches that already are having good competences in the pharmacogenomics. Okay, so this is happening all over the world right now. This is a poster. It was supposed to be an oral talk, but because of the COVID and everything happening, a poster that I shared in the last FIP PSWC 2020 that was supposed to be taking place in Montreal last May. Unfortunately, it went virtual, and this is the poster that I spoke about, the applications of pharmacogenomics in Alberta community pharmacists, where we are right now, and what are the expectations in the future in terms of legalizations, in terms of practice, in terms of knowledge, and in terms of grants and research. How to apply pharmacogenomics in precision medicine? As Dr. Pamela kindly mentioned, there are few guidelines out there. There is the CPIC website, and this is the website for it. Also, there is what we call the PharmGKB, and the PharmGKB, I will refer to it later, and I'll show you how to dig for information when it comes to some of the So basically, this is what I call the shop all, because it carries the CPIC guidelines, and it carries the Dutch, and sometimes it carries the Canadian. And other. If I want to implement the PGX in therapy management, I have to ask important questions. How is this drug eliminated from my body? For example, it's eliminated through renal clearance, through hepatic clearance, what transporters are involved, what phase 1 or phase 2 are involved. When it comes, to giving the efficacy, what receptors are involved into that. And then, so general questions of PK and PD. And then the second question would be, okay, does those do those enzymes and receptors have alleles? Okay, are those alleles having poor metabolizers or extensive metabolizers or intermediate metabolizers? Does the ethnicity I'm dealing with carry such alleles or not? So the functionality and the genotyping leading to the different phenotyping or functionalities. Okay, and then do I have enough research and guidelines through our resources for proper dosing? I cannot just say, I cannot depend on one research paper. It has to be guidelines, research groups that carry or grasp all those information and put it in a form of a guideline for people to be using. Okay, so do I have enough guidelines? Do I have enough research? Do I have enough data to allow me to change the dose based on this drug-gene interaction? Has it been identified, and how to reach it? This is I copied from the MyDNA kit that I use in my pharmacy, and they have here, they say, okay, so you can see that the 2D6 alleles, or the 2D6 is involved in those antidepressants, in those antiemetics, in those antipsychotics, in those beta blockers, opioids, analgesics, and others. The CYP2C9 is involved into here, losartan, phenytoin, warfarin, so anticonvulsants, antidepressants, blood pressure medications, statins, PPIs, voriconazole, antifungals, antibiotics, thrombosis. It's everywhere. You cannot say that PGX is only involved, can only used for thrombosis clinics, or can only used for oncology clinics, or pharmacists, community pharmacists don't have to get involved. No, actually, community pharmacists are dealing with all those. And if I'm talking about the scope of practice that we're having in Alberta, with the community pharmacists having the prescribing authority and can prescribe medications, and they can follow up on and can send to lab requests for their patients, and they can follow up on the lab results and adjust medications accordingly. With this scope of practice, community pharmacists have very good pharmacogenomics knowledge and have to add the gene-drug interactions to their things, which something that we have been working on at the university level, at the ACP, and at the Pharmacists Association level, and as a practice level as well. A lot of pharmacists did implement those kits. Okay, it's not on a bigger scope, but some of them have started, including my pharmacy. Okay, let me give you an example. So a patient comes in with carbamazepine. He has been using it for 4 months, stopped for some problems, including insurance coverage and hospitalization period, and the doctor wants to restart him on carbamazepine. The doctor phones you in the pharmacy and asks, he has heard about available pharmacogenomic testing that is needed for this patient. Would you strongly recommend doing this test? What are the gene, and why or why not? Okay, and so basically the patient did the test, and those are the results. But before that, let's go for the let's go for the PharmGKB. So you're gonna go, this is the PharmGKB website. So you're gonna go in here and you're gonna write carbamazepine. Okay, and you're gonna take the prescribing information. And you will find that there are 3 groups that did work or have guidelines that relates to carbamazepine pharmacogenomics. The CPIC guidelines over here, and the Canadian, actually 2 groups. So the Dutch did not jump in here. It was only the CPIC, the CPIC, and the Canadian. What genes involved? Those are the genes that are involved. Okay, so we're gonna choose the CPIC because it's the strongest, okay, are actually more commonly used. And you will find calculators in here. So you have to add the gene here for the calculator. You'll also have in the PharmGKB a summary of what are the expectations. You'll go down there, sometimes there are videos discussing, and then you will find the CPIC guidelines, the PDF for the CPIC guidelines, the year abbreviations or some here for the CPIC things, and then you will find some tables, and those tables tell you what to do. Okay, so if I have a homozygous alleles of the HLB1, okay, heterozygous, what sorts of alleles that I'm looking at, okay, so here it's HLA and HLB. So the CPIC put them both in one category, and they put some calculators for them. So I'm going to go for the patient again. So if I'm going to answer this doctor, I'm going to answer with the following. Basically, it's the HLA-B genes and HLA-A genes that needs to be tested. Whether it should be tested or not for this patient, it requires a good look at the guidelines because of what we're going to see now. So let's put the 1502 positive. We don't have information about the HLA, so I'm going to assume it's the other over here. Okay, and I'm going to confirm that he is positive for this one. The calculator would give you the results out there, and the results out there say, okay, there is an increased risk of carbamazepine-induced cutaneous adverse reaction, and those are Stevenson-Jones reactions and necrotic toxicity reactions. Okay, they have, yeah, okay. So let's see. So significantly increased risk of carbamazepine-induced cutaneous adverse reactions due to the presence of this allele. Okay, if a patient is carbamazepine naive, it's suggested not to use the carbamazepine. If the patient has previously used carbamazepine for longer than 3 months without showing any incidence of cutaneous adverse reactions, consider cautiously using of the carbamazepine. So when I go back to the scenario over here, the patient did use the carbamazepine for 4 months. He didn't develop, he well tolerated it, he didn't develop any reaction to it. So basically he can go back to the carbamazepine therapy. And in that case, because I already know that the guidelines, oh, I'm sorry, that's, oh. I already know that the guidelines are allowing this, okay? Then I could have initially even saved the test, and I could have not asked for it. It's more safer to do the testing, but in this specific scenario, I don't have an urge to do it if it's going to be a cost obstacle on my healthcare system. So this is an example. The second example that I have here is voriconazole, and voriconazole is used as prophylactic therapy for cancer patients. It's going to be found in protocols for that, but those patients, their immunity is very less, and if they get an infection, a fungal infection, it could be lethal. So the trough level of voriconazole for those populations should be not less than 2 micrograms per milliliter, and it's associated with worse clinical outcomes if this happens. So what are the CPIC guidelines for a patient with this specific thing? So I'm going to do the same thing here. I'm going to go for the PharmGKB. I'm going to go up there and I'm going to write the voriconazole. And I'm going to check the clinical guidelines, prescribing info. Okay, so here I have CPIC guidelines and I have the Dutch group guidelines, and they both relate to the CYP2C19. I'm going to go to the CPIC because it carries the calculator, and I'm going to implement here the 1 and the 17 thing. The calculator would come for me with the following the results. He's a rapid metabolizer. Rapid metabolizers, the enzymes are working more than usual, not the wild type. And as such, the clearance for this medication would be huge. And because of the clearance is huge, it's expected that the concentrations or the blood concentrations are much lower. And because of this, I might, the semen of this drug or the trough level might go below the 2 microgram. Okay, so for adult patient, choose an alternative drug that is not dependent on the CYP2C19 metabolism, because whatever drug you're using, since it's dependent on the CYP2C19 and it's a rapid metabolizer, it's going to eliminate it quite quick. And as such, we're going to be having issues. So they suggest using amphotericin B, posaconazole, or other things. Okay, so we're going to check what the guidelines are telling us and take the clinical decision based on that in light of the kidney function, the liver function, and the other things, because it's a therapy management. Okay, the University of Florida did some research about that, and they found this is copied from one of their conferences. So steady state trough plasma concentration, mean voriconazole trough level. So you'll see here the 1717, which is the rapid metabolizer, it's going to be less than the 2. The 117, which is like a little bit fast because it's one fast or one rapid metabolizer and one normal. So wild type with the fast. So this was a little bit above normal, but not the normal, not the wild type range, with the score activity usually above 1. So here it is more than the 2, and all the other genotypes show this range of the trough levels for the voriconazole. The prevalence of subtherapeutic troughs or subtherapeutic concentration for the 2C19 ultra metabolizers was 51%, and for other phenotypes was 16%. So the failure of therapy was above 50% for people who carried ultra metabolism. Okay, those are the guidelines. When we talk about tables, this is a picture of the table that you can see here. So for the ultra metabolizers, those are tables that you can see over here. For metabolizers, and those are the recommendations. And we have to look at moderate, strong, what is the level of evidence in here. I come back to the end of my talk. This is something I'm very enthusiastic about. I teach, I spread the idea, I advocate. Thank you so much for having me in here today.
Thank you very much, Dalia, for this very interesting talk. I think really you and Dr. Jacobson were really very complimentary and in the correct order for us to have really good idea about pharmacogenomics and so on. So I think I'm going to just ask you one question, and I think you are in a better position than Dr. Jacobson to respond for. As I have said, we have just launched the Egyptian Human Genome Project, and we are starting the establishment of precision medicine in Egypt. And you are familiar with the education here in the faculty of pharmacies. You left not so long ago. So how can we prepare ourselves and make our students more acquainted for this type of future therapeutics and using pharmacogenomics in pharmacies? So how can we change what we need to change in our syllabus and curricula and so on?
If we're talking about the general practice, Dr. Sameh, then we're dealing with all the challenges I mentioned. We need to tackle all the points that I did talk about. When it comes to knowledge, we have to implement those competencies. We have to print those blueprints that we're having, and we have to start implementing those competencies within the pharmacy curricula. I know that there are already a few pharmacogenomic lectures, a few genomics topics that have been started for the past couple of years to be taught in Egypt. I know it through friends, and I know it through colleagues that already are working in Egyptian universities. So there are a few courses out there, but we need to work more towards implementing the competencies. So we have to print in the international competencies, make sure that they are covered within our curricula. And eventually, so this is for undergrads, so this is for future generations. For the generations that have already been out there, we need to start working with the CE, like continuous educating units, through whatever we are used to do, like whether programs through universities or whether through syndicates of pharmacists, the courses that they have been given. We need to start working on legalization as well, since this has taken a national thing. So basically provide how to manage the data handling, and then start doing the awareness. More hands-on are needed for sure. And this is something that, yes, despite it's not starting too early in Egypt, but it's not too late, because everything now in the world is quite new.
Okay, I think we have another question from our colleague Dr. Ahmed Said in the US. Dr. Ahmed, if you can mute yourself and just say your question.
Assalamu alaikum. Thank you, Dr. Dalia, for this very informative presentation. As Dr. Sameh said, I'm calling from Buffalo, New York, in the US. So I have 2 questions for you, since you are an expert in the pharmacy practice. And we actually, you know what's going on regarding the COVID-19 vaccine and the recent announcement from both Moderna and Pfizer about the 2 vaccine candidates. Yes. Pfizer will soon apply for emergency use authorization for the vaccine. So my questions for you, first, do you think that it is currently safe for the public to take this vaccine in such a politically polarized environment? Second, do you think that the pharmacists and pharmacies are ready to handle the special accommodations of this vaccine?
Thank you, Dr. Ahmed, for your question. This is very important in whatever, like in the time that we're handling right now. I need more information about the two vaccines to be able to test whether it's safe or not. I cannot just say out there and give an advice. But if they will take the FDA approval with all the things that relates to the FDA approval, of course they should be safe because they have been tested on 30K or 70K or 50K, depending on the numbers and the data that we're going to see. Of population, whether it's going to be safe for everybody. Again, we have to look at the clinical data and we have to figure out, did they incorporate different ethnicities over there? Did they incorporate different people over there? This is something that we don't know, but I don't assume that big companies with big names like that would risk their history and name getting out something that is not totally safe, and neither the legalization bodies would allow it to. So if they get the legalization and everything, yes, for sure, it should be safe. The second question is whether pharmacists can do it or not. We expect that pharmacists needs to jump in because this is what we do in Canada, for example, for flu shots. So the regular flu program for the province in Alberta is distributed mostly through community pharmacists. So pharmacists can jump in, but as you mentioned, there are special accommodations. I heard about special temperatures and special things that needs to be for storage for such things. Again, this is it's a little bit of a very good question, but whether it's applicable or not, that's another question that we have to wait for the data. Things are a little bit in the air right now, so we have to wait for proper data to be able to give proper decisions about that.
Thank you, Dr. Dalia.
Thank you, Dr. Ahmed.
Thank you very much, Dr. Dalia, for really very interesting